Good evening to all of you. Once again, I take this opportunity to welcome you to the Calcium Masterclass, which is a pinnacle in management of coronary intervention. My name is Ehsan Raza. I work as a general manager marketing at Translumina, and I take this to talk a moment to talk about what does Calcium Masterclass has stored in for us. Calcium Masterclass is basically a program which has been curated and created for all the intervention cardiologies, which comes together every week to discuss on the finer aspects of calcium management. And as you all know, the world has moved from the wire, balloon, and stenting today to more complex management of calcium. Because as you all know, the epidemiology clearly speaks that today, because of the more incidence of diabetes, renal insufficiency, more and more patients and aging, more and more patients reports of calcium challenges. And what you need today is basically a tool which helps you to treat calcium better. And today's program is a program which really tries to democratize the treatment of managing calcium. And that is all about the intravascular lithotripsy. But before I have the privilege of introducing the great set of speakers coming in today, internationally and nationally, and the moderator of the evening and some great expert panelists coming together to add a lot of value to this program, I would take this opportunity to have a brief sneak peek into what does Translumina as an organization stand for. We are a company which is continuously exploring limitless possibilities to see that the products, the access of the product is at your doorstep. And that is why we created some wonderful strategic partnerships all over the world with great companies like Shockwave, C Switzerland, Asahi, to see that these products are available, to see that your armamentarium is full of various tools which makes treatment much more easier. We are a company with 3 manufacturing facilities with a global footprints in more than 80 countries. And not only that, we are the only company in the world today who have stents which are having 10 years data, be it polymer or a polymer-free stents. We are so proud of sharing with all of you that no company in this world have an RCT of 10 years. We're the only one to have achieved this great feat. Not only that, sir, in fact, we are not stopping here. Our quest to have exploring limitless possibilities, we are continuing to lead in disruptive therapies. Very soon, you will see that we are creating boosting catheters. We'll get products on mitral valve replacements and aortic valve replacements and various balloons, which will help you to treat your patients better and better. And talking about our great darling of all the managing calcium is the Shockwave today, the IVL product. And here I would like to stop press that very soon in the TCT, we are going to be more wicked this time and much more smartly wicked. Why? Because we would like to have and share a lot of data, and especially the data this time going to come on nodular calcium. And I think this is one of those basically the data which you all were looking out. How does Shockwave IVL basically performs when it comes to nodular calcium, which is sometime in the holy grail, or it comes an Achilles heel of managing calcium. You'll get to hear from the experts all over the world. If somebody is attending TCT amongst the audiences or the speakers, please do attend this session. This will be a very, very interesting and exciting one when you are all there to learn more about it. And in order to take this evening forward, I have the privilege to have Dr. Nitin Tiwari sir as the moderator of the evening. Dr. Nitin Tiwari sir today would be taking us. He's from Nagpur, who would be taking this program forward. And I also take this opportunity to welcome Dr. Angel Chances Ricalde from Spain, who is the speaker today. Basically, he's someone who has come with a lot of milestones in his career. He is presently, Dr. Angel is presently a director of intervention cardiology unit, cardiology department of University Hospital at Ramon y Cajal at Madrid, Spain. And he brings about more than 2 decades of experience working in various hospitals and various departments in part of Spain, in that part of the world. He's one of those finest, endowed with a person with great degree of educations. He has done his master degree in health management and directions from Atlantico Medio University Business School. Not only that, he's one who has contributed immensely to the field of intervention cardiology through his myriad publications on index journals. That is some of his achievements which he has done in the field of intervention cardiology. Not only that, his contribution to the field of intervention cardiology right from publication goes to publication of textbooks, which helps people to improve their pearl of getting their knowledge. And not only that, he has been someone who has been endowed with a lot of various other publications and various awards, and he has contributed to many chapters, many monographs, and textbooks, and he has been given a greatest award of the Associate MSD of poster sections in arterial hypertension in scientific section of the Spanish Society of Cardiology for his great paper on hemerological alterations in insulin resistance and ventricular mass in hypertensive patients. So I think he would be the speaker and the chairperson of the evening to take this and he would be speaking, and his great experience on the field of intervention cardiology, especially with shockwave IVL, he brings a lot of experience. So sir, over to Nitin Tiwari sir, who would be moderating this session. I would request to take this evening forward and introduce the chairpersons, the speakers, and you can invite the first speaker of the evening, sir. So over to you, sir.
Thank you for the honor, and thank you everyone for chipping in. First of all, a grand welcome to Dr. Angel Sanchez Recalde from Spain. It's really an honor to listen to him. And I think he'll be presenting the first case, maybe the slides. He'll be presenting the, how does he go about, what is the best practice to do, how does he does the IVL. So let us hear first from him. And then we have a lot of panelists. Let me introduce the panelists who are there with us today. I hope most of them have joined. Dr. Amit Kumar is an associate director and senior consultant from Sarvodaya Hospital, Faridabad. Dr. Sanjay Bhatt is a senior interventional cardiologist at Aster CMI Hospital. Dr. Sunil Gonial is a cardiologist from Naran Hridayalaya, Raipur. And I think Dr. Partho Chaudhary also is from Jamshedpur, Mediterranean. So I welcome them. Dr. Arijit Ghosh from Kolkata, Salt Lake Hospital, Amri Salt Lake Hospital. So all the panelists are welcome. And I think there are 3 speakers. I'll be introducing them once they present the individual cases. I think without wasting much time, let's hear from Dr. Angel. What are the best practices while using IVL in complex cases? Over to you, Dr. Angel, sir.
Okay, thank you so much. And thank you for a very nice presentation. Can you hear me well?
Yes, we can.
Okay,
yes.
Thank you. Hello, everybody. As you said, I am Angel Sanchez Recalde, interventional cardiologist working in Ramon y Cajal Hospital in Madrid. And it's an honor and a pleasure to me stay here and participate in this very, very, very interesting webinar about the managing of calcified lesions. The learning objective is to understand the mechanism of action of IVL when we treat different types of calcified lesions to establish suitable indications to IVL in order to optimize clinical outcomes of our patients and to update the long-term clinical and OCT data of coronary IVL from pooled disrupt cut trials, and finally to see some of label indications where so we can work perfectly. As you know, a shockwave system has 3 components: the generator, the connector, and the catheter that is 6 French compatible. And the balloon sizes vary from 2.5 to 4 millimeters with a single length of 12 millimeters. The system has 2 emitters that pulse once per second. In total, 80 pulses per catheter. Obviously, it's a single use. And the electrical energy is delivered to the emitter, initiating the formation of a steam bubble, which expands and collapses rapidly, creating sonic pressure waves. Sonic pressure waves travel through the vessel with an effective pressure of 50 atmospheres. So actual energy delivered into the calcium is sonic or acoustic energy and is capable of cracking hard material, as you can see in this video. The balloon is not a low profile balloon, as you know, but it goes over the traditional wire that you use. So we don't need to change it and use another specific wire, such it happens with ablation techniques. You can wire the side branch and there is no risk of damaging the second wire or the side branch. And shockwave pass through the plaque wall enable modification of deep calcium. There is no embolization risk because the disrupted calcium remains on the wall. Lithotripsy technology enables also using a balloon inflation at low atmospheres, avoiding the risk of perforation or dissections associated with high pressure inflations. Finally, and it's easy to learn because it's a balloon-based technology and the learning curve is quite flat. This slide shows that in cadaveric superficial femoral artery using micro-CT after IVL treatment, there are multiple vertical and horizontal fissures in the calcium. On the right side, in the histological samples, you can see the multiple fractures in multiple directions in the calcium that increase the compliance of the vessel and allow to stent expansion. The clinical efficacy and safety of shockwave therapy was evaluated in multiple clinical studies. The most important, as you know, is DisruptCAD3, a single-arm IDE trial for FAV approval in US with 384 patients. And recently, we have data from a pooled analysis of 4 trials assessing the safety and effectiveness of IVL. 628 patients were included from 12 countries. Procedural success defined as stent delivery with a residual stenosis less than 30% by QCA without MACE was very high, 92.4%, and delivery stent rate was very high, almost 100%. MACE including cardiac death, myocardial infarction, and cardiac vessel revascularization at 30 days was only 7%, mainly driven by non-Q wave MI related to the procedure. In this slide, QCA demonstrated that an increase in minimum luminal diameter immediately following IVL treatment and with further increase post-stent. And remarkable, this technique has a very few angiographic complications, no perforations, no reflow, only 1.8% of flow limiting the dissections. That decreased to nearly 0% after stenting. So the rate of angiographic complications is too low using this technique. And let me introduce the case. One is a 70-year-old man with hypertension, diabetes, long previous history of cardiovascular disease, as you can see in the left part of the slide, of this slide. The patient had, in summary, the patient had a drug-eluting stent in the proximal circumflex and another one in the proximal LAD. And the last event was unstable angina. And the angio, as you can see, shows a severe and very calcified lesion in the proximal LAD. So in this case, the first strategy was to use a low-profile balloon, 2 millimeters, and then pre-dilate with a cutting balloon, 3.3 millimeters of diameter. But a dog bone image happened, indicating balloon under-expansion, as you can see in this video. The same image was obtained using an OPN, no compliant balloon, 3.5 millimeters of diameter. So we use OCT to see what happens, to see the morphology of the plaque. As you can see, the SKY 2020 algorithm indicates that when there is an inadequate balloon expansion, and intravascular imaging should be used and is mandatory to understand the mechanism. In this case, OCT shows multiple intimal dissections normally after the scoring balloon, and as you can see, there is a very, very, very thick and circumferential calcium, but we don't see any fractures after a scoring balloon. So if we follow according to the OCT calcium score, more than 0.5 millimeters of thickness, 5 millimeter long, and 50% of calcium vessel arc, there is a risk of stent under expansion, and a modification plaque technique is needed. So in cases such as this case, a large vessel, deep, thick, and circumferential calcium, shockwave balloon is the preference. As you can see, we achieve an spectacular cracks into the calcium, as you can see the OCT images. And then the next step was to implant a drug-eluting stent at 4.428 millimeters with a very good angiographic result. And as you can see, the OCT showed a good expansion, and behind the stents, the deep cracks into the calcium, as you can see in the images. This is the post-dilation in the proximal part of the stent and of the stent, and this is the final, the angiographically final result. So how about the OCT information after IVL? Today, we have information from a large data set coming from the pooled analysis of OCTs of studies, including 262 lesions. In this case, lesions were grouped according to the arc of calcium by OCT, and there were no significant procedural differences across these subgroups. So that means that the effect of IVL in these subgroups are not influenced by the procedural technique. Importantly, the minimal stent area and the degree of stent expansion observed by OCT after IVL treatment were similar across all these different subgroups of calcium arc. So this device works perfectly and similarly in concentric and eccentric calcified plaques. After IVL, visible fracture were observed in nearly 70% of the lesions, more frequently in circumferential calcified plaques. Normally, that is because there is more amount of plaque to see. And remarkable, independently of the number of fractures after IVL that I see, and regardless of plaque calcium arc, we can obtain similar minimum stent area and stent expansion. That is what we are looking for. So that patient I presented, the 1 year follow-up, an elective angiography, the patient is asymptomatic, and this is the good angiographic result, and also the OCT follow-up 1 year show no restenosis and the same cracks as you can see in the calcium. So talking about the long-term follow-up, now we have also 1 year follow-up data of patients from Disrupt Cat3 that represent the largest and longest clinical follow-up available in patients treated with IVL. This study, as you see, as you know, included a very high patient risk profile with high percentage of comorbidities, such as renal insufficiency, and with long and severe calcifications. But nevertheless, the clinical outcome at 1 year is quite good, considering the baseline characteristics of the patients with MACE rate of 13%, mainly driven by MI within the first month. Interestingly, in this subgroup analysis, no difference were found across the subgroups, except in patients with longer lesions, more than 25 millimeters. So the combination of heavily calcified and long lesions is the worst combination in terms of MACE, mainly suffering periprocedural MI. And recently in PCR 2022, Dr. Hunton presented the follow-up OCT data from CAT3 and CAT4 studies analyzing 160 patients. The endpoints were TLF and stent thrombosis. And the main finding is the low rate of TLF and stent thrombosis at 1 year, only 6.9%, mainly driven also by periprocedural MI, only one subacute thrombosis at day 22. Are spectacular results. According to OCT findings, patients with TLF had a greater maximum calcium NGO, but no differences were found regarding the presence of calcified nodule or calcium thickness in patients with TLF or without TLF. If we focus the post-stent OCT findings, there were no differences in terms of maximum area, expansion, eccentricity index, or strut malapposition between the two groups of patients with or without TLF. So let me introduce a second case. Is an 82-year-old woman with several risk factors, including chronic kidney disease, that was admitted to the hospital with inferior myocardial infarction. She underwent primary PCI, and in a second procedure, we treated a severe calcified lesion in proximal LAD and left main coronary artery. This is the angio. Coronary imaging in this case didn't cross the lesion, and the first step was to do rotational ablation with a 1.5 burr. IBUS showed a calcified lesion, as you can see. This is the IBUS. And this is a calcified lesion and a nodular calcification in the ostium of the LAD. After rotational ablation atherectomy, we didn't see any fracture in the nodule. And my preference in calcified nodules is shockwave, and we used an IVL balloon 3.5 millimeters. After IVL balloon, we clearly observe multiple fractures in the nodule, as you can see in the images, and predicting a good expansion of the stent, mainly in this patient who is the hospital manager's mother. I am not kidding. And finally, 3.5 millimeters drug-eluting stent was implanted according to distal diameter of the vessel with a pod using a non-compliant balloon of 4.5 millimeters. This is the angiographic result, a good angiographic result. And I will show a very good and a circular stent expansion in the region where the nodule is or was. So in my opinion, calcium nodule is the most difficult part of calcium morphology to treat. Our objective should be to crack the nodule the most we can in order to obtain the best result in terms of stent expansion. So the typical location, as you know, of calcium nodule is mid-RCA and proximal LAD. They usually are located in severe calcified plaques, and the sub-studies of OCT from this root cut study showed no differences in the stent area and stent expansion between lesions with calcium nodules or without calcium nodules. Nevertheless, there were more visible fractures and more importantly, more strut malapposition rate in patients with nodular calcium. The same finding was also observed in the 1-year OCT follow-up cohort of CAT3 and CAT4 patients presenting the last EuroPCR. And the clinical implications of stent malapposition in nodular calcification needs to be clarified in future studies. Numerically, in this study, there were more events in the group of nodules, but there are no significant differences because of the low number of patients included, as you can see. In the patient that I presented, was a woman. Currently, we know that women with calcified coronary plaques treated percutaneously had more MACE than men, and specifically had more risk procedural complications following rotational atherectomy, such as dissections, coronary perforations. And in this recently published pooled analysis of CAT trials, women were older with more comorbidities, a smaller vessel, and shorter lesions. Nevertheless, there were no differences in MACE or procedural success after IVL treatment. IVL in women was not related with more procedural complications compared to men, no perforation, no slow flow, and less than 2% of severe dissections. At 1-year follow-up, women showed a flat curve of MACE and no differences compared to men. And so finally, a very, very, very short case, 84-year-old man with multiple risk factors, previous stent in RCA, and a pacemaker. And now he's admitted to the hospital with a lateral MI in the middle of the night. Angiography showed a thrombotic occlusion of the mid circumflex, as you can see in the videos. And we predilate with a compliant balloon 2 millimeters, and the artery was opened. Then what is a myocardial infarction, and then we implanted a 3.5 drug-eluting stent. The stent was underexpanded, and we used a 3.5 non-compliant balloon, and also a 3.75 non-compliant balloon. We didn't solve the underexpansion, as you can see in the videos. In the mid segment of the stent, and this scenario of primary PCI in the middle of the night, we use an IVL balloon 3.5 millimeters, and immediately we achieve an excellent result. This is the angiographic result. This is the OCT. So the role of IVL in stent underexpansion, conceptual concern that nowadays is off-label indication, conceptual concern that electrohydraulic lithotripsy discharge could damage the polymer, the drug, and indeed the metallic stent itself. So information about IVL in underexpanded stent are very limited, few registries and a small number of patients, but the technique works perfectly in this off-label scenario. So just to conclude, IVL has shown sustained low rates of clinical events at 1 year. OCT sub-studies have demonstrated consistent results regarding stent expansion and all different types of calcium morphologies. OCT sub-study suggested sustained stent expansion and adequate healing at long-term follow-up. Excellent procedural safety and effectiveness outcomes to 1 year in women after IVL. And for the reason maybe can be the first line therapy for plaque modification. And off-label use of IVL may be safer and more readily available than laser of rotational atherectomy in underexpanded stent. And thank you so much for your attention.
Thank you. Thank you, Dr. Angel. That was a wonderful presentation. At the outset, before we have asked any questions, let me introduce the chairperson for today, Dr. A. Gopi sir. He's an eminent interventional cardiologist with over 26 years of experience, and is a past president of CSI Bangalore and Karnataka chapter. He's an expert in complex angioplasty, TAVI, mitra clip, and all other valve replacement things. So let me welcome Dr. A. Gopi sir. If he has any questions or any suggestions. This was a wonderful presentation by Dr. Angel. And if there are any questions, all the panelists and speakers, Dr. Abhyankar, Dr. Chaudhary, Dr. Tripathi, and all the panelists which I have introduced earlier, Dr. Kumar, Dr. Bhatt, Dr. Konial, Dr. Chaudhary, Dr. Ghosh, anybody of you, if you have any questions with Dr. Angel, I think we'll try and fix it right now. Then we'll go by every presentation.
Actually, one of the concerns with IVL that, sometimes we think about those maybe theoretical, when we do a left main intervention, the fact that we have to keep it, on for so long, and then once the pulses are stopped, we need to wait for some time. That moments can sometimes be very scary. So, what is your experience with that? Doing, a left main without any support? How do you, do that?
IVL in left main coronary disease, I have experience, and I think it depends on the patient and the instability of the patient. If in stable patients, we can do perfectly, because the time that you are inflated the balloon for the pulses is very short, and it works perfectly because it's the left main is a large vessel, and the problem is a patient with ventricular dysfunction and or in patient in an unstable condition. In these cases, maybe you can do it quickly, but my experience is good, because the time that you are using the IVL and the pulses is really very short. And then I think it's important to keep more time the deflated balloon, and to wait more time to restart another rate of pulses. But my experience is quite good.
Okay, thank you.
And what is generally the size, Dr. Angel? Generally, the most commonly used size for left main, the balloons for IVL?
The balloon is 1:1. Maybe even for left main is the normal is for 4.45 millimeter balloon.
Do you recommend pre-dilating in the left main? If it's a very critical block, maybe we can dilate with a 2.5 or 3, a normal balloon, and then go with IVL just to be safer side to prevent ischemia?
It's a very good question. If you have a very critical or severe lesion, it's good to pre-dilate with a low profile balloon, and then to create a good channel to go with the IVL. And yes, it's true. Is in left main coronary artery is a good thing to create a bigger channel to keep the flow because it's important for the patient. I usually do it before IVL, and also pre-dilate with a non-compliant balloon to reassure that the future stem expansion will be good.
Okay. So I think let me tell the first presenter, the next presenter to keep the presentation ready. I think Dr. Abhyankar will be presenting.
So Dr. Abhyankar has some technical problem. He's going to join within a few minutes.
So maybe
we can have
Dr. Tripathi then. Dr.
Yeah,
Gaurav
we can
Tripathi?
have Dr. Gaurav Tripathi. Sir, in the meantime, sir, in the chat box, Nitin sir, there are 2 questions have come for Dr. Angel, because the chat box is with me. So unfortunately, sir, I've not been able to transfer.
Yeah, I'm not getting it.
Sir, with your permission, sir, if I ask these 2 questions from sir on behalf of all the audience who is someone has texted given in that, sir. So the first question, Dr. Angel, they have asked is that how do you determine the selection of the size of IVL balloon? For example, when the artery is very tapering one, let me give you an example. He has written that suppose the proximal is about 3.5 and the distal is about 2.5. Now, in this condition, generally, how do you determine the size, and what size would be the right size to pick up? This is the first question. And then the second question I'll tell after this, sir.
It's a very good question. If economically you can, you can use 2 balloons. But no, it's a joke. I try to use the balloon 1:1, the balloon to the ratio to the reference diameter of the vessel. And in this case, I prefer to use a bigger balloon because it's a non-compliant balloon, and the risk of perforation at 4 atmospheres is very, 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 very low. And I prefer, if you need to use IVL into different interpreted lesions, I prefer to choose the bigger one.
Okay. Maybe IVUS can help. IVUS or OCT can help us in the sizing of the vessel if cost is not really the issue. Yeah.
Yeah, I use IVUS or OCT in all complex calcified lesions. For me, it's mandatory to do it because it's the only way to assure that the result is good, and to choose the modification device, because nowadays we have atherectomy or rotational atherectomy, we have orbital, we have IVL, we have cutting balloons, we have a lot of devices, and it's important to choose one of these devices, and the information is from imaging, from coronary imaging.
Yep.
Thank you. The second question, sir, is that they have some colleague of yours have asked is which has been one of the rarest of the rare experience he has experienced. What he says that although with the advent of the new balloon which is there, it has found to be 3 times more durable than compared to the earlier balloons which IVL had. Still, what they found a very peculiar kind of instances he has shared is that during the mid pulsing, it means that during when he's giving these pulses during the mid cycle, after maybe 43 pulses, the balloon has ruptured. Now, generally, the balloon gets ruptured right at the beginning. But have you had an experience of this nature? If this was your experience, is what could be the probable reasons for this? Can you attribute any cause and effect relationship between these?
I think it's a very good question, and yeah, we had some balloon ruptures, IVL balloon ruptures, but I think it's not the problem of the balloon. Maybe the problem is the plug. When you have a nodule into a very severe plaque, the balloon can rupture. The new generation is better, but I think for me, I had a very few ruptures, and it's not a problem. But it can occur. It's very infrequently, but it can occur. And the new generation of the balloons will improve this complication.
Okay, before we tell Dr. Tripathi to present, one last question I wanted to ask Dr. Angel, sir. Sorry for the time, but in case of an under-expanded stent, if the patient is not affording an IVL, it's costly in India. So how do we go about it? Whether we do rotablation, whether we do a scoring balloon or a cutting balloon, and if we do it, whether we need to stent it, or suppose 20% under-deployed stent is there, under-expanded stent is there. Despite despite all precautions that we have taken, and despite everything, despite plaque modification, if there is still 20% under deployed stent, then how?
I think it's a very good question, and the last case illustrated this. This is my case in an emergency procedure in the middle of the night, and I try to do it quickly because in the morning I had to work, and I do a balloon and then a stent, and yeah, you have an expanded stent in a myocardial infarction when you are thinking about thrombus and not calcium. And in the end, I can solve an acute situation very quick using an IVL balloon. I think it's the simplest and more effective way to treat an expanded balloon. Before IVL, I had experience with laser. Laser is a similar technology, and I do. I think I don't remember, but a long time ago, I used rotational atherectomy. But rotational atherectomy, I think, is not good for an expanded stent. It's dangerous. You can suffer from complications, perforation, or the bore could be trapped into the plaque.
Yes.
And to me, the treatments are laser, or nowadays IVL. IVL is quicker, simpler than laser. I mean, for me nowadays is off-label indication, but for me is the gold standard nowadays.
And the cutting balloon, what are your opinion? If we use a cutting balloon, whether we need to stent it?
The cutting balloon, it works. I use it from time to time, or after rotational atherectomy. I think it's a good thing to create a channel and then to try to rupture with a cutting balloon. But it depends. If you have a large vessel, for me, the best indication for IVL. It depends of the calcium. If you have a superficial calcium, maybe a cutting balloon it works perfectly. But if you have a very thick and deep calcium, the scoring balloon doesn't work. And it depends of the length of the calcium, the depth of the calcium. It depends on the findings of coronary imaging. It's very important.
Okay, great. Thank you. You're wonderful, and you answered most of the questions so nicely. Thank you so much for that. I think without wasting much time, let us hear Dr. Gaurav Tripathi.
Am I audible, sir?
Yes, you are. Yeah.
And my slides are visible to you, sir?
Yes. Okay. Please go ahead. Yes.
Thank you, sir. This is I will be discussing a case what I have done IVL in this scenario. So not to waste the time, I will just start. So this was a 63-year-old male, a known case of type 2 diabetes mellitus and CAD earlier. He had a history of inferior wall MI 6 months back when he was diagnosed as having triple vessel disease. PTCA, RCA, and LED was done at that time by me only. And LED stent was not very well optimized back then because of a huge calcium chunk. At that time, I used Scoreflex balloon to optimize it, but it was not sufficient enough to actually do it. So plan was to do PTCA, LCX, and optimization of LED stent. That too after 6 months in this such patient. So this was an angiogram right now after in next sitting when we can see a patent RCA stent, and then instead way to will go to left system where there is a calcified tight stenosis in the proximal segment of LCX and extending into proximal segment of OM as well, and we can see the stent from osteoproximal LAD which is mild, that not too very great expansion achieved in the first part. So this is the stent in the proximal segment. We can see the huge calcium chunk around, but not very well expanded stent in the proximal segment. And LCX is definitely a huge calcium chunk there present. So plan was to do an OCT first and look for the calcium, and then plan accordingly. So we put a cyan blue wire, park it distally, and while inserting OCT catheter, there was such a tight lesion that OCT was telescoped. You can see this. It got broken. So because of such a tight lesion, OCT catheter was broken at first glance, and then we pre-dilated the tight portion with 315 balloon, and after that, since there was a huge calcium not allowing us to pass anything further, we inserted guide lines with anchor of this balloon. And even after Guidezilla, OCT was unable to cross the tightest segment of LCX. So, and broken again. So we did not be able to have more OCT catheters. So we abandoned the plan of doing OCT in these patients. So now anchored another balloon and trying inserting Guidezilla even further beyond the lesion. So such a huge calcium chunk, only with Guidezilla, there was some balloon was crossing. Otherwise, very difficult to negotiate these lesions. And even after dilatation, Guidezilla got trapped now. So we have to deeply intubate the catheter and slowly trying and removing this Guidezilla in trapped Guidezilla. And after some maneuvers, finally succeeded in getting it out. Now, when Guidezilla is out, no balloon is passing again. So we have no other option just to intubate Guidezilla again and do some pre-dilatation and then have an IVL balloon in the place. So after the Guidezilla inserted here, we plan to deep intubation of some balloon and then started IVL balloon dilatation. There was a 310 balloon. Started giving pulse. So these were the pulse in the distal and the most calcified segment now. So now after even after IVL, we should also always do a post dilatation with an NC balloon, because what IVL does is makes calcium very fragile. But again, you have to break it with an NC balloon. So we did an NC balloon after IVL. And then we inserted an stent 3 size with support of Guidezilla, definitely, because again we have some speculation that even after IVL patient might not pass to such a tight lesion. And after placing it on the ostia, we dilated it. So during all this time, what we missed is the OM. It means that OM is slightly having some slow flow, and we were so much engaged into this Guidezilla and LCX OCT thing that we actually forgot that we have to save OM as well. So again, it is very difficult to remove the balloon as well, stent balloon. Now after stenting LCX is very nicely seen, but we cannot see any OM now. So what we thought is, let's optimize LED first, and then we'll see the OM. If it happen to gain some flow, then we'll leave it. Otherwise, we'll negotiate it as well. So some post stenting 6 months later optimization probably. This was what done by me that day. So LED stent was implanted 6 months back. Now I'm optimizing it 6 months later with IVL. So we can see 4 pulses of 10 seconds were given in the proximal segment. Even after 6 months, gain well. So some lumen gain observed in the proximal segment of LED, and now we can appreciate the difference between pre-IVL and post-IVL definitely. So after the stenting, although I have done OCT post-stenting, post-IVL in this LED patient, and it was very well optimized. I don't have an image right now with me, but it was very well optimized after IVL. So the third task was to negotiate the OM. We tried it with the sand blue wire and then pilot wire, but again, it was very difficult call because of the curvatures. So we did some intracoronary medication and having gained some flow. So after some minute being passed, there was TME2 flow seen in OM. So that was all at that day from my side, because I was not oriented to negotiate it further OM, because it is having TME2 flow. Distal flow was very well done, achieved. Although there was a tight segment, if I would be able to negotiate it, then I would definitely love to, but I was unable to. So PTCA, LCX, and optimization of LED is done. Stent done, and OM has to be to flow as a final result of my IVL case. Thank you, sir.
Yeah, thank you, Dr. Gaurav. So, any comments from the panelists? Dr. Amit? Dr. Amit Kumar?
Hey. So it was a nice case. So I will appreciate his efforts, and Dr. Gaurav did a wonderful job, I will say. So, but I will ask you whether it was wise to optimize after 6 months when the endothelialization has been done, doing IVL in the LED stent. What is your opinion?
See, sir, I was again not very well aware about this recommend. I was knowing that there is an off-label indication of doing IVL in post-stenting patients, but when first time there was an when I did put LED stent, I scored the part well. I did cutting balloon even after optimization, even after stent dilating it. I didn't achieve the result. So what should we do? If stent has been implanted already and you see there is not properly optimized, you have only 2 choices left. That is, one is OPN and one is IVL. And since I was doing IVL already in this patient, so I choose the IVL. It's a decision part. I think the house is more. House is welcome to give their opinion whether it is wise decision or not. But at that particular day, I decided it. OPN balloon could be a good choice, but again, the endothelialization part could come into play in that scenario as well. IVL is safe. IVL is good to play with, and IVL is definitely one of the we achieved results as well. We documented on OCT. Although I do not have image right now, but definitely trust me, I hesitate. The IVL did well in this patient.
I will welcome from other doctors.
Yeah. Any comments? Any other doctor? Dr. Bhatt, Dr. Konia?
Why didn't you think of doing an OPNNC balloon at the outset when you do the LED plastic?
Sir, at that time, actually, OPNNC was not available in our shelf. So otherwise, I would have done that. And LCX stenting, I can see the calcium was used there, and IVL was definitely required. So it was my decision. When I will be doing LCX, definitely IVL will be required. So I can plan this. Although I was planning it earlier, but the patient delayed somehow and come back again after 6 months. But I planned it around 1 to 2 months later, but patient came in 6 months later, then I planned accordingly. So many times it's not in our hand to call our patient, but that because of calcium chunk in LCX, I decided to go with IVL simultaneously in the both arteries.
Yeah, actually, I have experience of optimizing the stents after primary angioplasty. When you bring in your patient for the next angioplasty after a couple of weeks or within 1 month, At times during the primary angioplasty, we fear to do a post-dilatation because we anticipate some slow flow. So I have experience regarding this post-dilatation during the elective angioplasty of the other vessel, non-culprit vessels. But I am not very sure whether it should be recommended after such a long time.
I mean, I think it's a, I mean, personally, I think it is a good decision. It's better to have a, good size vessel. And okay.
Yeah, that's true. That's true.
Since the polymer is already inside, the damage to the polymer, damage to the stent may not make much of a difference to the final result. So I would think that is a good thinking, and
yes,
large diameter probably may give us better outcomes.
yes, even Dr.
I think under
Dr. Tiwari,
expanded stent is better than what he has done.
No, I personally feel, Dr. Tiwari here, I feel that he has done a good job. One, because leaving an under expanded stent and just 6 months. I mean, okay, anyway, we are giving one more stent. So we need antiplatelets for at least a year, dual antiplatelets, and that will take care of that stent also. And having an under deployed stent is not a very great option. I believe if, cost issues are also there in a country like India. If you are opening an IVL balloon, naturally the pulses, if they are remaining, use it rather than, had it been a wonderful stent, had there been an OCT done, and we were reasonably sure about the size of the vessel, then we would have not done it. But I think it was a visibly a very under-deployed stent, especially in the proximal osteoproximal segment. So I think there's no harm in doing that. That's what I feel.
Dr.
I think
Atul
wants to ask a question. Please go ahead.
Kind of comment. One is that you mentioned that you kind of overlooked that OM. But I think the problem of putting your guidezilla, etc. But the OM should have been wired right in the beginning, because that would have given you a better trackability also because of the double wire.
Yes, it's a good suggestion.
Your balloon through.
Yes,
the second thing is because there was no imaging, but whatever balloon I saw looked fairly well expanded before IVL. I don't know whether I'm right or not, but the balloon that you did and then you took the guidezilla line, it looked fairly well expanded. I don't know whether it was just a routine balloon, OPN, cutting balloon, but it looked well expanded. And the last comment is that we see time and again stents which have been undersized by us or by somebody else in previous procedures. But unless there is a restenosis or unless there is a significant growth, I think there is no evidence of any kind to say that they should be re-optimized at a later stage, because there were so many. Sometimes we see LED stents of 2.25 in mid LED, which have been put previously maybe by us also, or maybe by somebody else at that time, because at that time, maybe due to primary setting, it has been undersized. But if there is absolutely no restenosis, I don't know why would you just want to optimize that later stage.
I mean, since he did imaging,
since I was
one
doing
of
for LC
that he could actually have seen what is a minimal stented area diameter, and if it was less than 6, it's only been 6 months. I would still say that I think maybe it could be an option. Yeah.
So since I was choosing to PTCA LCX already, if had been there been no LCX, definitely I would have looked. Okay, we can leave it and expand it. But since I was doing LCX standing,
yes.
so why not to use the opportunity?
Yes, I agree with you at least. Yes, Dr. Gaurav, there are at least 2-3 people who agree with you. I think I would have also gone ahead and done that. No harm. Endothelialization is a very small issue. It's not a very big issue, I believe. It will anyway happen. I think let's go with the second case.
Dr. Gaurav, hi, Dr. Gaurav. I just have one question actually.
So,
yeah, have you seen? I mean, it's a good result actually. LCX is looking very good. Have you also, imaged the left main or that bifurcation area, because it looks diseased?
Yeah, it is diseased.
Left main looks diffusely diseased, and the osteoproximal segment of LED is it covered with a stent?
Osteoproximal LED area was actually not covered with the stent. Intended not covering with the stent. But we just try to during the first time when we did the LED stenting, we tried to leave the ostia.
Okay. I just thought,
if I happened to cover the LED ostia, I would definitely pulled it over into left main and covered
left
it.
Left main only, yes.
Yeah. It looks actually diffusely diseased. Left main looks diffusely diseased along with the ostium.
Look differently. There is a shaft which is almost of the same lumen to LED LCX that does not follow the guidelines. So definitely left main is diffusely diseased. We can appreciate that, sir, as well. But I tried OCT doing OCT and LCS, but was unable to do that. What I did was post optimization OCT of LED.
Okay.
Okay.
Sure.
Okay. Thank you for the good case. There was a great discussion. I think let's hear Dr. Atul Abhyankar, sir. Next case.
Can I share my screen?
Yeah, please go ahead, sir.
Yeah.
I
Need
think
to stop sharing too.
Dr. Gaurav needs to stop sharing.
My screen is visible now?
Yeah.
Yeah.
Yeah, it's visible.
Okay, so I'm just going to show a case which, in a way, can be called a simple case, but it can land you into sometimes trouble either at the time of doing the procedure or immediate post procedure or even at a later date. So the idea of showing this is that I'm a kind of aviation buff, and this is a pilot's radar showing two storm sort of warnings or storm phases there. And then the decision is whether one would push through hoping that you are going to come safe out from the other side of the storm, or make a decision to divert and take another path, change altitude, etc. So this is a 61-year-old male hypertensive who presented with exertional angina of class 2 to 3. The TMT was strongly positive. He had a smallish circumflex which was treated before by one of my junior colleague who was my ex-student, and that was done. Now I'll show you later on that the plan was to treat circ and RCA. So the circ was a simple lesion and it was treated for smallish circ. But after taking it for RCA intervention, actually it was decided to stop and do it in a place where all the facilities are available, which was, I think, the very right decision. Looking at the storm ahead, you have to sometimes pull back and then make a call. I don't know whether you can appreciate that there is a lot of calcium in this vessel, a pretty tight lesion, moderately long lesion, and a lot of calcium. So I think sometimes it may be difficult to appreciate the calcium. So this is the stent boost image that you can see, and I think even without any imaging, this is good enough to tell you that there is a very horrible amount of calcium present there, and therefore the decision that was made by my colleague was to refrain from moving forward in the previous situation without having imaging, without having IVL. So sometimes you have hope against hope. It means basically you know that you are going to have trouble, and sometimes you still want to persist. So it is better to sort of refrain from that and go with the proper imaging and then decide what is the strategy. As you can see here, it was redilated with 2 millimeter balloon. Even a 2 millimeter balloon did not expand properly. This is just the OCT run, but this is just to show you that if you can appreciate some amount of calcium and the tightness of lesion. This was after a small balloon dilatation. So this was because we were not sure that the OCT catheter is also going to go through very easily. And the next, I'm going to show you the OCT run. Now, I'm just going to run the OCT full run for, I don't know whether you call it visual pleasure or visual pain in this situation, but, and then I will show you some fixed frames to appreciate the calcium. As you can see here, you can see there's a big chunks of calcium. Now you have this calcium all around, very thick calcium everywhere, right up to as you come proximally. And then at the proximal end, after the circular calcium, you will appreciate that in the very proximal end, there is also kind of nodule, as you will see here in the end. So let me just show you some of the fixed frames. So as was mentioned in the earlier lecture, that we have various criteria, and if you look at the the various parts of this lesion and all the criteria. So this was calcium in some places, which was 360-degree calcium, very thick calcium. You can see here it is about 1.1 millimeter in thickness. So in a pretty big vessel, as you can see the size here, that it is about 3.78 or 3.84 millimeter vessel in the proximal end. Also a reasonably good vessel, about 3.5 vessel at the distal end. And looking at this imaging, I think most of the times it's the choice is very clear, because the good thing about the IVL, choosing IVL, is that it appears to be a relatively safer method to me. You know, we don't have a very huge experience, but whatever few cases we have done, it is a kind of safer experience compared to going to very high pressures, in my opinion. So this is the now the next decision making when you have a moderately long length of calcium is where you, because if unless you have unlimited resources and you're going to use 2 IVL catheters, the issue is about how do you optimally utilize those 80 pulses. And the strategy was that we do first in the proximal and mid area and then go distally, because we thought that the distal segment was not so bad in terms of the amount of calcium. So we sort of tried to optimize it, use the maximum amount of pulses in the proximal and the mid part of the lesion. As you can see here, it is after a few pulses also still not expanding, eventually expanded in all the areas. You can see the distal part has expanded in a single sort of cycle of, 10 cycles here. And so we utilize the remaining this thing again in the proximal area. And now this is sort of the result. You can see sort of dissections there, but a fractured calcium. And this is the OCT run. I'll skip this. So this is the OCT run, and this is after the IVL before doing anything else. So this is just immediately post IVL, and I would want you to appreciate as to how the calcium has cracked in many places. And so you have to decide as to how much calcium is really cracked. And as mentioned by some of the previous speakers, that after IVL, you still sort of have to optimize or do further balloon dilatation with high pressure, if required, maybe even with some kind of cutting balloon. So this is how it is after IVL. These are the steel frames. You can see how wonderfully here as to how the calcium has cracked into multiple pieces. Similarly, as you can see here, that the lumen post IVL, this is even before any balloon dilatation, immediately post IVL, you can appreciate the amount of cracking of calcium that is present here. So you obviously optimize. I will try to sort of skip. You can see here that now the balloon is expanding. And in the proximal area, as you can will appreciate here, in this area, in spite of IVL and in spite of very high pressure balloon dilatation, there was one point which was still sort of causing a little bit of an issue. But after vigorous post dilatation, we put the distal stent and then the proximal stent. So I will try to sort of skip this. And so this is the result. You can appreciate that in the proximal part, there is still some amount of unexpanded area. There is a kind of tiny hump or a speed breaker like situation in this picture in the proximal, sort of towards the proximal end of the proximal stent. And you can appreciate in the stent boost here as to in this area, there is still some issue because of calcium in spite of all this. This is just to sort of say that if we would have just tried with any high pressure balloon dilatation, it was going to be so difficult that in spite of such good cracking of calcium, it still needed a lot of extra pre-dilatations, etc. So this is, you can see this is the post stenting OCT, and after this is after sort of initial post dilatation of the stent. So I'm just not stent implanted, but stent post dilated. You will appreciate that now that you have got a nice circular lumen, the vessel is pretty well expanded. good area. But you will appreciate that I'll just show you in the end that when you come proximally, there are some still unopposed ends, and I will sort of, as you will appreciate here, that there are still some unopposed ends. So we took, we had already done with 4O balloon, then we did it with 4.5 millimeter balloon to sort of oppose this stent further. So this is a utility of imaging also, that sometimes you feel exhausted having done a long procedure, but if you confirm with imaging that all you have done is as good as it could be, then that's really helpful. So this is post PCI sort of analysis. You can see excellent lumen area or in the mid 7.17, 806, and in the proximal area of about 11.3. And this is the picture in the end. So this is the final result, pretty good in spite of such a log. So you must have heard in the military parlance, there is a term which we heard in Iraq war called shock and awe. But when you have these kind of calcium, you use a shock wave and it gives awesome results. Thank you.
Yeah, thank you for a wonderful presentation, Dr. Abhyankar. Maybe Dr. Angel wants to comment. Any comments, Dr. Angel, sir?
Yeah, it's congratulations, Atul, because it's a very nice case, and you did it perfectly. You stopped in the first procedure, and you rescheduled the patient maybe a few weeks after the first procedure, after the first angio, and to plan the PCI. The options you choose my strategy is to go with a small balloon to create a channel and then to use IVL, because the IVL creates the IVL can increase the compliance of the artery, not only to break the focally the calcium, and also avoid very long dissections. If you use a non-compliant balloon or cutting balloon, a very big balloons, the dissections are very big, and you have the risk of rupture. For this case, I prefer to use a small balloon only to open and create the channel, and then to use IVL. In this case, you check the result with OCT. You saw several fractures in the whole area of calcium. Then you reassure that a good expansion with the stent, and the only thing is a small underexpanded segment, and is where a nodule is. At the beginning, you show a small nodule, and this is the area in the nodule where you show in the end the small underexpansion, but the result was spectacular, well done, without any complications, and very quick. Congratulations! I think I'll do the same. I will do the same.
Yeah, thank you, sir. Any other comments, or maybe let us go with the last case for today. In the meantime, any questions we can discuss? I think Dr. Chaudhary, Dr. Gaurav Chaudhary is presenting.
Yeah. Can I start sharing my slides?
Yeah, please go ahead. I think there are no further questions. We'll discuss one final time after your presentation. And
hope my this slides are visible.
Yeah, they are visible. Yeah, please go ahead.
Yeah. So very good evening to all of you. I would be just discussing my sound calcium strategy. So starting with the case one, I would discuss the algorithm along with a few cases. So this is the case, 58-year-old female having angina of class 3, and it has a recent onset. She has a change in the precordial lead suggestive of critical LAD, and so angiogram was done, and this was the angiogram. So you can see there is some 30 to 50% left main disease, and there is a angulated LAD with critical narrowing. And this is the AP view showing a large diagonal along with this two bends before the last lesion. So a decision for CABG was taken, but the patient was unwilling to go due to her frailty and refusal by the surgeon, although she had a high syntax score. So a plan to this do the imaging guided PCI of LAD and whether required debulking or this IVL was planned. So the most problem in this case we can see is the angulation. So it was a challenge whether the imaging catheter would pass or not. And in this trying this, two IVL catheters become defunct because it was so angulated that it was not going through. So we just pre-dilated also the lesion, and by the third attempt we were able to cross the catheter. So it's very angulated, and it led to some dissections at the time of this ballooning, and this was the OCT image. So there was some micro dissection, and we can appreciate this dissection along with a calcium that is coming, that is around 270 to 360 degree calcium with some intimal serrations, and it is almost a concentric thick calcium. So even in the DISRUPT series trial, 20% of the cases required a guide catheter extension to cross the imaging catheter. So it was in our mind that now applying what are the options. So the options is the calcium, it is more than 270 degree and it appears to be thick. So these are the two scores that we often follow. One in Fujimo score, that it's a 50-50 rule if it's more than 5 millimeter in length, if it is more than 0.5 millimeter in thickness, and arc more than 180 degree or more of the 50% of the circle. So this case sufficed these three criteria, and there is IVAS score that I will discuss in my last case. So we plan to go with some therapy. So this is a common slide that we often see. So in this particular case, the balloon crossability was there, and on this imaging we saw that it fits the criteria or more than a score more than 3. So it was a deep calcium, so it was tried with the lithoplasty balloon. So 2 lesions were dealt.
Your voice is breaking, Dr. Gaurav.
The IVL balloon has frozen the speaker.
I believe we have lost him.
So
we don't see him, sir.
yeah. Can we tell him to rejoin, or?
We have already told him, sir, to join. Chandan is doing it, sir. Chandan is on the job, sir, to do that.
In the meantime, anybody would like to comment?
He's joining. Dr. Gaurav is joining.
Yeah, regarding the rupture of the balloon, I've also seen quite a few cases, maybe 2 cases I've seen. And that balloon ruptured not very early, but yes, after maybe around, say, 15-20 pulses. So I believe the nodule, as Dr. Angel has said, maybe that might be the reason. The plaque itself might be the reason. But yes, I've witnessed quite a few. But luckily, in that case, before rupturing, the balloon did its job. Because see, there are a lot of cost implications also in a country like India. So we cannot open another balloon because it's massively costly.
Yeah, I know. I have also some cases, and yeah, I use a new balloon, but the theology is the plaque behind the calcium. I think it's not a problem of the balloon. The important thing is to de-air the balloon avoid air embolization. But
Yes.
it's a very uncommon complication, but it can happen. And my question is with IVL balloon, do you think we need burns more than 2 millimeters for atherectomy, rotational atherectomy? Do you use large burrs, or
No,
with
sir.
IVL? With IVL, I think it's largely obsolete to use bigger burrs.
Yes.
Yes,
yes, I saw in your slides, I think after 1.5 millimeter burr, you straight away went to IVL catheter. So even in my practice, I don't go beyond 1.5.
Yeah,
1.5 is the usual. Maybe around 85% of my cases are generally 1.5 only, and the remaining are 1.25 if it's a very critical kind of calcium. Otherwise, I don't oversize. I don't go by 2 millimeter burr or anything. I don't go with that. Generally, I stopped using. So I agree with you. Yeah, Dr. Gaurav.
Am I, sir, audible?
Yes, you are audible. Yeah, your slides are visible.
Yes. Sorry for, I don't know what happened, but so 2 days continuing the same case. So easily 2 days were implanted with good post-dilation was achieved. And then as per the algorithm, we'll move to the next case. So it's a 60-year-old male, hypertensive, non-diabetic, angina for 1 year. And he had an inferior wall MI 3 months back. We did RCA and this LED stenting. So RCA and LED was done, and his circumflex was remaining. It has a critical disease. So this time the patient reached to us, and this was the angiogram. The right RCA stent was patent. So we can see a stent from the mid to proximal to ostial LAD. Stent struts covering from ostium to mid LAD, and the circumflex was seen to be critical, and there was some OM lesion, and it was a critical disease at 2 to 3 places. It was a very long lesion in the circumflex. So once we engaged this catheter, the patient also developed pain. So this is the case in which we tried to negotiate this catheter, but what happens if the micro catheter doesn't cross? So then we are left with the direct rotawiring. So in this case, we tried everything. We tried to put micro catheter or a small balloon, but we are not able to cross the micro catheter to that lesion. So probably we thought there might be some struts that be protruding toward the LCX ostium that is caught in the region. So, but we did this, try to cross the micro or IVUS catheter, but nothing was going through. So ultimately, we tried to directly rotawire this lesion, and multiple wires and multiple attempts were done as the patient was having the ongoing chest pain. And at the end, we were able to successfully cross this wire. So there was some doubt whether we have gone through the struts, but having the ongoing chest pain, we didn't have any option. So we tried to sorry, something going wrong. Sorry for the interruption. So hope the slide is visible. Not able to. Coming on to the case. So the slide is visible, sir?
No, it's still loading. It's still loading.
No, it's visible now. The slide is now visible, sir.
Okay. So after a lot of attempts, we were able to cross the wire, and over this, we tried to do the rotablation as he was having the ongoing chest pain. So the thing in mind was how to cross this angulated lesion. So we tried that after generating some heat as the ostia, we may be able to modify the strut, any strut that is looking toward the L6 ostium. And after a lot of efforts at high RPM around 2 lakh, we were able to modify this and we were able to enter this lesion. And once I entered the lesion, then the second hurdle was just to cross this lesion, middle lesion, and it crossed, but the third lesion was not giving away. So again, I have to go to the very high speeds, that is around 2.2 lakhs. And in the end, this could be crossed. So once the wire was there, balloon was there, and we pre-dilated this lesion with non-compliant balloon. And in the end, which was not even taking a rotabar or anything, we were able to implant this 2.5 into 48 days. And the IVAS was done from LAD to left main to look for any disruption of the LAD ostia, but fortunately there was no significant dissection or compression, and FFR to this lesion was normal. So I think this would be a case where I think only rota would work. Now coming to the case 3, IVAS assisted and IVL assisted PCIO of LAD and left main. 70-year-old male, classical angina, normal EF, distal M 50 to 70% disease, and LAD 70 to long calcified disease. So this was his angiogram. We can say that we can appreciate there is a distal left main shelf along with a disease starting from the proximal LAD to the mid LAD. So this was the angiogram in the epicranial view. We can see these are highly calcified lesions and a critical stenosis, and in the array caudal, it confirms the same. So in this, we are aware that if the arc is more than 360, we often give 1 point. If the arc is more than 270 and the length is more than 5 millimeter, you give 1 point IVAS. And if the diameter is less than 3.5, then you give a point of 1. And if it's a nodule is there, you give a 0.1. So what about the imaging in our case? So this was the distal reference vessel, and this was a catheter, IVAS catheter, that shows around 270 degree of superficial calcium, and at some places it was around touching 360 degree. So this was the IVAS image, and coming on to this was the first, and this was the live IVAS image, and coming to the next. So there was not only a 270 degree arc in the proximal part, we also have a 360 degree calcium, and there was a signal drop. Beyond this, there was a post-acoustic shadowing, so there was a lot of calcium, and there was a concern about the left main, and we did left main estimation, and in this the left main also shows to be significant. So this was the IVAS images of this patient in the proximal LAD, and going towards the left main. So we can say in left main the area is less than this, around 5 millimeter square. So we thought we'll have to deal with both distal and the proximal lesion. So we can see there is a lot of eccentric, this plaque with some calcium, and in this you can also see there's very critical narrowing that can be seen in the distal left main. So in our patient, IVAS score was around 3 because the lesion diameter in the mid LAD was less than 3.5, the length was 5 millimeter. We also have an arc touching 360 degree in the proximal part and more than 270 degree in the mid part. So as per the algorithm, going back to the same algorithm, we can see this is appears to be balloon crossable lesion, and it can be crossed easily. And on the imaging, we saw that it was a deep calcium as well as superficial calcium, having both this arc more than 180 degree, length was also more, and thickness also appeared to be more, as it was no reverberations were seen. So this was planned to put judicially use a 3 into 10 balloon and to give 40 pulse in the mid and the proximal part of the LED. So the pulses were given, and it was seen that this balloon opened up. And the most beautiful part of this patient is we could see a very beautiful fractures. So this in the middle part of this in a bit earlier, and you can see this 4 cracks in the above image, left upper, and in the right side also you can see there was a break in the calcium. So objectively we can see that the lesion has yielded up and the calcium has been fractured, and IVUS appears to be a better modality for calcium in while assessing in the fractures also. Okay, so it's the last slide I would just come. Okay. And in the end, this dash to the proximal to mid LED was done, and the left main PCI was also done by keeping a wire in the circumflex because it showed a significant disease in the left main in the IVUS. So I will share the last picture of the PCI. Hope it is seen. No? So 3x40 dash was done, and the left main was also extended by keeping a wire, and this was the end result. So there was a good opposition, and we did the pot with 4.5 balloon in the left main. And so the take home message from my presentation is we should, when we are looking at the moderate calcium, we should quantify this calcium by OCT or IVUS. IVUS being the preferred as it is more sensitive and specific for calcium. And once we see arc more than 180 degree or thickness more tan 0.5 or more than 5 millimeter length, then we should try to switch to IVL or rotablation. If the microcatheter is not crossing, then of course the rotablation would be of much help. But if we are able to pass our balloon, then I think of course the IVL would be a preferential choice because it has lesser complications. So this is almost again one of we are all aware with this algorithm, and I just try to accumulate all the cases that can be discussed so that we can clearly remember this algorithm in our mind. So, but sometimes the rotablation would be a must because in circumflex, especially ostial circumflex cases or mid circumflex cases, and many times we'll need a guide catheter extension to bring this burr toward the lesion. And quite often there would be some cases where we need a both. A rotatripsy would be good to achieve a good end result and a good MSA. So thank you all for patience listening. Thank you.
Thank you, Dr. Gaurav. Any comments? The closing comments? Anybody?
I think it's congratulations because it's a very good presentation with a clear messages in uncrossable lesions. The rotational atherectomy is the first choice. Is clear, and when you have a large and also a deep and thick calcium, maybe the IVL is the first option. Do you have experience, or we are talking about the OCT or IVUS? Which technique do you prefer to evaluate the calcium, or you choose the coronary imaging depending on the characteristics of the patients?
I think, sir, we use both, and I have a more experience with OCT, but I think IVUS gives an advantage that we can change the strategy. If we are not able to cross the IVUS catheter, then we should go with rota, and if we are able to pass the IVUS catheter, then all those rota options may not be good. So we can identify this calcium in more sensitive and specific way, and visualization of calcium and before the IVL and after the IVL. After the OCT, the cracks are not that good visible because the dissection are many times subintimal. But with this IVL, I've seen in so many cases, the fractures are very good, are visible, are more appreciable. So I think for calcified lesion, we should try to prefer IVUS more.
Yes, your point well taken. Yeah, I agree with that.
I think I have, sir, one question to Dr. Angel. Sir, we all have been trying to optimize our result after stenting and all that, but especially in calcified lesions, and if you put a stent, and after the imaging, you get a good MSA, and residual stenosis is between 10 to 20% angiographically. So I don't think there is any need to go for further NC or something like that, because the MACE is not going to be that great. And especially in the case Dr. Gaurav that has shown, that was excellent case. But I think if we could have seen on IVUS, it had a MSA more than 5.5 or 6. Then I think there is no sense in going with IVL or any NC or OPN once the patient is stabilized, and you get a just, because we should be satisfied with 10 to 20% narrowing. That is called as a successful PCI. Narrowing up to 10% is accepted. And in calcified setting, we should be satisfied up to 20%, because after that we invite complications. So if we are using imaging before this procedure, then optimization, and if it is the MSA of 90% of the distal reference area, then I think we should stop there rather than chasing the each and every percent of the case.
I completely agree with you. Yeah.
Dr. Nitin sir, one more question in the chat box for Dr. Angel is, looking into the economy of products like IVL, and at the same time the kind of options available with the clinicians of managing calcium. Various tools are available like rotablators, OPN, cutting balloons, and so on and so forth. And the new kid in the block is the IVL. The question here being is asked is, what all accessories are complementing each other, and they have their own role in the clinical armamentarium. But if one has to cherry pick the IVL, what could be those compelling indications and compelling profile of patients where this would be the only choice, and none of those clinical tools which are available to treat would not be the best option? So if you have to cherry pick 3-4, he has asked for 4 clinical scenarios where you think this is the only right and the compelling tool set. So what would be those 4 according to you?
I think it's a very good question. It's not clear, and we have a lot of devices, and you have to choose. To me, the first option to use IVL is when I see a large vessel with a concentric calcium, also a very thick calcium. And in these cases, when you have a very severe calcification by angio, and then you check by imaging that is circumferential and a very deep calcium, for me is the only solution, because ablation rotational ablation is not a solution. Orbital is not a solution for very thick and deep calcium, and the only solution is IVL today. For the rest of the cases, when you have a superficial calcium and circumferential calcium, not superficial, you can choose another way to treat, a cutting balloon, non-compliant balloon. But for large vessels, deep calcium and thick calcium, I think is the main indication. Other question is for nodules. Nodules is another issue. IVL, I have some cases with OCT, with IVUS. IVL is capable of rupture and to create several cracks in the nodules, and also orbital atherectomy. Maybe there are 2 good options. It depends on the patient, the vessel. But I have to put the best scenario for IVL is that large vessels with a very severe circumferential calcium and deep and thick calcium.
Thank you, sir. So, Dr. Nitin Tiwari, sir, over to you, sir.
I think yes, and I think one more addition we can have is I think if we are optimizing the stent. After putting the stent, if you feel you need something to optimize it further, I think rather than rota or a scoring balloon or cutting balloon, I think IVL scores. So I think it was a wonderful session. And I think it was very engrossing, very engaging, and very the knowledge sharing was excellent. And thanks to Dr. Angel in particular and all of the people who have contributed today, all the panelists and all the speakers, chairperson, everybody. A big thank you. And it was wonderful to learn from all of you people today. And I think with that, I think we should end this because it's already 1 hour and 40 minutes. I think it's enough. And I think let's keep something for the next time also. And it was great to be with all of you. It was a pleasure to hear. Thank you, Dr. Angel, and thank you, everybody. Thank you, Translumina, and everybody who has contributed for this evening, wonderful evening. Thank you so much.
Thank you so much. It was a pleasure.
Good night,
Thank
everyone.
you.
Good night.
Bye-bye.
Good
Goodbye.
night. Good night. Bye. Thank you.